Hi everyone, my name is Jenny Delwich and I'm one of the nursing professors in the undergraduate program here at the School of Nursing, and Dr. Crary invited me to speak to you today about epidemiology. I wanted to give you a little bit of my background and explain why I'm the one who's going to be talking to you about epidemiology today. Most of my history in nursing is in the emergency department, the outpatient department, and in hospice care. From that time, I did learn how to integrate surveillance and other aspects of epidemiology into the care of our clients. But why I'm really speaking to you is because I'm also at Marquette in a PhD program and have just completed a course in epidemiology. I'm also working on a research practicum with an epidemiologist in which we're going to look at interpersonal violence in vulnerable populations. So I'll speak to you at the end a little bit of how we use epidemiology to look at vulnerable populations. First, to start today, I thought we'd talk about the definition of epidemiology. Epidemiology really is the study of how disease is distributed in populations and the factors that influence or determine the distribution of disease in populations. What we're talking about, or the reason we talk about epidemiology, or the premise underlying it, is that diseases don't have normal distribution throughout the population. There are things within each of us that, certain characteristics that make us at higher risk or protect us from a variety of diseases in our communities. And so we really want to look at that and see what that pattern is so that we can do things to help prevent diseases. The objectives then of epidemiology include, number one, the identification of the cause or the etiology of disease, but also the risk factors. If understood, we can help to reduce morbidity and mortality from a variety of diseases. We also want to determine the extent of the disease found in any community to see how much it is impacting that community and then have proper intervention. The study of the natural history and prognosis of disease is another objective of epidemiology. If we better understand it, then we better know how to treat and prevent it from occurring. We also want to evaluate both existing and newly developed preventive and therapeutic measures that we have for diseases and the modes of healthcare delivery. And we can use epidemiology to do that, so we know what is helping, what is preventing diseases, and what might need to be changed. Epidemiology also provides foundation for developing public policy, and that's related to environmental problems, genetic issues, other considerations regarding disease prevention and health promotion. Epidemiology can help us better understand how to focus our efforts in all of those areas. So when we look at those objectives regarding epidemiology, we're really looking at it from the perspective of an epidemiologist, and so we need to consider that then with the overlap with nursing. So can you identify then what ways registered nurses could undertake or have certain actions that can help support the attainment of those goals of the epidemiologist, and then how we can utilize the findings of epidemiology in the care of our patients, both at an individual level but at a community and population level as well. One role of epidemiology is really to monitor the changes in a population over time. This can help shed light on the health of a community. So an example of that might be that when we look at the leading causes of death in the United States population in 1900, really infectious diseases were the top 3 leading causes of death at that time. We were looking at pneumonia, tuberculosis, diarrhea, and enteritis, which were all infectious diseases. We just did not have the tools to treat that appropriately at that time. Now, if you look forward, and we've kept these statistics and we've kept this data over this time, by 2011, the top 3 causes of death were chronic diseases, not infectious diseases. So those were heart disease, cancer, and chronic lower respiratory problems. Again, that helps to tell us a little bit about the health of our population over the time and some of the advances in medicine and technology that have occurred in our population. Again, this information is really key to determine our health goals for our population, areas of research, focus for healthcare, and really preventive measures that we need to do. Healthy People 2020 is based on a lot of the epidemiologic findings that we've had over the course of our time in our history in the United States. A major use of epidemiology is to really use the findings to help identify subgroups in the population that are at high risk for disease. And the reason we want to do that is we can then focus our preventive efforts to the populations that are most likely to benefit from them, and then identify those risk factors through the study of those populations, identify the risk factors that we could possibly modify and help to prevent any of these diseases from occurring in the first place. So when we look at the epidemiologic approach, we really want to determine that there is actually an association between exposure or a factor or a characteristic of the person and the development of the disease. So we want to look for that causal relationship. We have to derive then appropriate inferences about the relationship to see, is it causal? So what we can do is through observations that people have, we can then do some further study to find out if there's a causal link or a relationship. So a while back, there was an observation that communities that had high levels of natural fluoridation in their water had corresponding changes in the levels of their dental caries for their population or their cavities. And so they had to do further study to say, is it causal? Did indeed the elevated levels of fluoride in the drinking water actually prevent or decrease the amount of dental caries that we saw for that particular population? And we found that they did. And so from that, then fluoridated water or purposeful fluoridation of water occurs. Another example of the use of epidemiology is an historical one. In 19th century Europe, in England, there was a devastating problem with cholera at that time. The prevailing thought at that time is that cholera was due to miasm, or a cloud that hung low on the surface of the earth, and that people who lived at a lower elevation would be at higher risk for developing cholera than people who lived at a higher elevation due to the cloud being closer to the earth. Now, they did do some look at the numbers of people who had cholera and where they lived as far as elevation, and in fact, that theory did bear out. However, there was one particular anesthesiologist at that time by the name of John Snow who just didn't agree with the thought that that was indeed the cause of cholera. He really believed that the transmission of cholera occurred through contaminated water. At that time, the water companies took their water from the Thames River, but from different areas. And the Thames was very, very polluted, but one water company got the water from an area of the river which was not as polluted. So Snow, in order to really test out this theory, decided to go from house to house. And when he went from house to house, he not only gathered information about who had died in the home, where the home was located, but also where their water came from. After he did that and found and correlated all the findings, he did indeed find that it was related to contaminated water and not a miasm. Of course, we know now exactly what the agent is that causes cholera, but at that time it was not yet known. Now, when we look at epidemiology, it's important to consider the epidemiologic triad. Human disease results from an interaction of three things: the host, the agent, and the environment. Now, a vector is often involved, a vector being a carrier of some type of disease, whether it be viral or parasitic, whatever the case may be. Now, none of this should be new information from you. I'm sure you've covered that before in a variety of nursing courses, so I'm not going to spend a lot of time on it now, except to say it's important to consider all three of those pieces of the epidemiologic triad. Not least of which, especially from the perspective of the nurse, is the underlying health status of the host. Of course, the host has to be vulnerable in order for there to be a disease process that occurs. Now, there are some things that we need to consider. How do we use epidemiology? And we really use it to measure the occurrence of disease. So a couple of things we can do include morbidity measures. Morbidity measures really look at the rates and proportions of what's going on in a population for certain disease processes. So what we usually do is start with an attack rate, or what we'll be talking about first is an attack rate. Now, an attack rate is similar to an incident rate, and it's really defined as simply the number of people in whom an illness develops divided by the total number of people that were at risk for the development of that illness. We use this specifically when we're comparing risk of a disease for certain groups or those with different exposures, so that we can see exactly what is the risk and why did some develop a disease and not others. We can use this often for food contamination cases or very acute cases where it's more clear to see an attack rate. For an example, you should have a slide that will come up and show you an example for total persons who were exposed to contaminated food. So the first table that you'll see again, says the total number of persons who ate each specified combination of food items. And the food items included tuna and egg salad. And so what we're trying to do is find out, of these total number of people who ate certain food combinations, who became sick. Now, there's a possible, in this example, they're looking at a possible contamination of the food sources with group A streptococci. Now, the second table that you'll see will tell you about the total number of persons who ate each food combination and then who later became sick with acute sore throats. So what we would want to do is think about what the definition of the attack rate is. So again, the number of people at risk in whom an illness develops divided by the total number of people at risk for development of the illness. So if we have this information and we wanted to know what the sore throat attack rate in persons who we say ate both of the food sources, egg salad and tuna, we could use the information in these tables to help to calculate that attack rate. Number one, we would look at, okay, which part of the table do we have to take a look at? The ones that, again, ate both the egg salad and the tuna, the total number was 75. And of those who became ill, those who ate both the tuna and egg salad, there were 60 cases. So if we took the 60 and divided by 75, then we would have our attack rate, which was 80%. Morbidity is another measure that we use, and morbidity is really defined as the number of incidence rate is a measure of morbidity, and what that is defined as a number of new cases of a disease that occur during a specified period of time in a population that's at risk for developing a disease. Really, when we talk about incident rate, the new portion of this equation is the important part. Again, we're looking at the number of new cases of a disease occurring in a population, not current cases, but new. Now, we're taking that number of new cases of a disease occurring in the population during that time frame, usually a year, and we're dividing by the number of persons who are at risk of developing the disease during that time period. For this measure to be really meaningful, to look at incidence rates and the measure to be meaningful, any person who could be included in the denominator must have the potential to become part of the numerator. Okay, so remember, your numerator is the number of new cases of the disease, and the denominator is anybody who's at risk. So again, for it to be meaningful, you have to have the ability to actually move into the disease category for that to be a meaningful number. So an example of that would be if we're looking at the incidence rate of testicular cancer, we know that only men can be in the denominator, and if we took the entire population number, it would not be a meaningful number because women simply are not at risk for having testicular cancer, clearly. Another measure of morbidity is prevalence. Prevalence is a little different than incidence. Prevalence looks at the number of cases of a disease present in a population at any specified time. Again, we're usually looking at a year's time frame for ease of measurement. This is divided by the number of persons in the population at that time. Because of population measures, we usually use a mid-year population count to do this calculation. The difference between incidence and prevalence is that prevalence can be viewed as a snapshot or just a point in time when we're really looking at the population and how the population is overall doing in regards to a disease. We really are trying to determine who has the disease and who doesn't. We are not determining when the disease developed, but simply who has it and who does not. And that's the difference between both incidence and prevalence, incidence again being new diseases. So again, we're going to work on an example. In this example, we're looking at the population in Atlantis at a specified time. As you can see from the slide that you have available, we're looking at March 30th, 2003. The population on that date was 183,000 for Atlantis. We're looking at TB cases occurring between January 1 and June 30th of 2003, and we have both new cases and active TB cases in general for that time frame. So the first question you have is what is the incidence rate of active cases of TB for that 6-month time period listed above? And so you would want to look at this information and try to figure out, going back to the definition of how we calculate incidence, how are we going to get to our final answer? So just take a moment and try to work that out. If you were to look at this table, the information you need for accurate calculation of an incidence rate is the number of new cases, in this case 26, divided by the total population, or people that would be at risk, and that would be 183,000 for Atlantis on this date. So if we take 26 divided by 183,000, we would also take that times 100,000 to get a 14 per 100,000 incidence rate for new active cases of tuberculosis. If we're going to compare this to the calculation of a prevalence rate, again, we have the same information on the table as we had with the previous slide, but our calculation needs to change because prevalence is a different indicator of morbidity than incidence. So in this case, if we wanted to calculate the prevalence rate of TB at this time frame for this population, we would go ahead and divide 264, the number of active cases, by 183,000, the population at that time, or those who would be at risk for development. We again would take that answer times 100,000 for the correct answer of your option showing being C, 144 per 100,000 for your prevalence rate of tuberculosis. We do additional measures and calculations relating to mortality. Mortality, of course, is indicating more death rates for certain disease processes. We can certainly look at an annual mortality rate, which would be all causes of death over 1 year, and we look at that, as we said earlier, historically to see how the population is trending over time and where our efforts need to be located in regards to healthcare, education, prevention, and interaction with our clients. Again, mortality rates serve as measures of disease severity, and they can really help us determine whether treatments for diseases are more effective or have become more effective over time. So think back to that historical example we started with. Infectious diseases, while not the leader anymore, still continue to be a problem, but in fact chronic diseases are taking the place, so need more time and attention to those issues. If a disease is very severe or very lethal, the mortality rate can serve also as a surrogate for incidence rate, again because of the time frame you're looking at. There are many, many different types of mortality rates, so the annual mortality rate that we're starting with is a pretty basic one to begin with. So when we're looking at an annual mortality rate of all causes, we're looking at the total of number of deaths from all causes in 1 year divided by the number of persons in the population at the mid-year point, and that's just the measure we usually use for consistency. We take that number and multiply it by 1,000 to get our annual mortality rate from all causes, and then you can see on the slide there's also some differentiation or some further delineation of what those causes were. We also talk about a case fatality rate when we talk about mortality, and that's more of a percentage. And what we're looking at is a measure of the severity of a disease. So we look at the number of individuals that have died during a specified period of time after the disease onset or diagnosis, divided by the number of individuals with that specified disease. We take that times 100 to get our percentage, which would be our case fatality rate. We would like to look then, as an example on this next slide, as the comparison of mortality rate and case fatality rate. So if we were to calculate the mortality rate in the population, an example we have up, the population at mid-year is 100,000, the disease X, or the number of sick in 1 year, is 20, and disease X, or the number that die in 1 year of that disease, was 18. If we were to calculate the mortality rate and the case fatality rate, these two numbers will actually tell us a very different picture. The mortality rate is really not that bad. We would have 18 cases divided by 100,000, which is our population, which would equal a mortality rate of 0.018%. Does not sound bad. However, if you were to compare that to the case fatality rate, we had 18 new cases with a total of, 18 people who passed away. And for the total, out of the total of 20 who were diagnosed, we look at a 90% case fatality rate. That tells a great deal more to a practitioner than the overall mortality rate for that disease. This is because the disease is very rare. If we only have 20 cases in the population of 100,000, that's a rare disease. There's not a high incidence. Therefore, your mortality rate is not going to be high. However, once the person has the disease, their chances of dying are very great, 90%. This is a really good indicator of the severity of the disease, and that mortality rate just won't give us that clear picture. So a real-life example that we see is rabies. It has a very high mortality rate, very high case fatality rate, but the mortality rate will actually look low because the frequency of the cases is so small. Another way that we use epidemiology in healthcare is looking at validity of screening tools. Of course, we want to screen our patients so that we can better identify cases of illness or disease processes so that we can intervene quickly. Now, in order to screen appropriately, we really have to have measures that are valid. And so validity is the ability to distinguish between who has a disease and who does not. And we can further break that down into sensitivity and specificity. Sensitivity is the ability to test any test, to identify correctly those who have the disease, where specificity is the ability of the test to identify correctly who does not have the disease. Why is this important? It's important when we do a screening program because we often have a large group of people who come to our screening programs, and if those people screen positive, we are going to refer them for further testing, more invasive testing, and also more expensive testing. And so the issue of false positive has to be considered because, number one, you have a client who now believes that they have tested positive for a disease. If it's a false positive, they actually don't have it, or we have poor sensitivity, then it can be a burden for them as far as worry and anxiety until they do further testing and find out indeed they do not have the disease. Again, the burden on the healthcare system would include the cost of doing more invasive tests to make sure that the client does indeed not have that disease. Conversely, if someone has a false negative result, the problem is that if in a serious disease, they would delay getting treatment because they believe that they actually do not have the disease with a false negative. Again, the importance of false negative really depends on the nature and the severity of the disease that's being screened for. So if it's a highly fatal or highly serious disease and we tell the client that they have tested negative when they have indeed not, then again, that can have negative, possibly fatal consequences for the client. So to calculate sensitivity and specificity, we would look at test results and look at true positives, false negatives, false positives, and true negatives. And that calculation can be seen on the bottom of your screen. We're not going to get too much in detail about how to do that, but just recognizing the importance of the sensitivity and specificity of tests when we do our screening for our clients. Depending on where you go to work, you will have the opportunity to use different tests, and they should have reports about the level of sensitivity and specificity, one being higher and one being lower typically. What I'd like to wrap up today with then is the importance of surveillance. We've talked a little bit about how to do calculations. We've talked about the importance of epidemiology and utilizing it within our practice, but really we have to talk about surveillance and why is that so important. When we're talking about surveillance, we're talking about all the information that we gather in order to do some of those problems or use that data in a meaningful way. And what we do is we gather the who, when, where, and what, and so we can utilize that information that has been gathered to answer the why. And nurses can really assist in surveillance. There are certain reportable cases that you will have depending on where you work. And if patients come in seeking care and they test positive for some of these diseases, they're a mandatory reporting situation to different agencies. There are very clear definitions wherever you work on what those cases are, and a lot of that is mandated by the state in which you work. There are state notifiable diseases that are mandatory for reporting so that we can follow up with clients who test positive, and also so we can collect the data to see how are we doing with control of this disease, prevention of this disease, and treatment. There are also other ways to get information. We can look at death certificates, which is a great a source of information for looking at epidemiologic findings and doing some studies with that, and also administrative data like billing. And we can look for things like morbidity and mortality calculations. Again, you'll become very familiar with how you utilize all of these things through your care. So at this time, I'd like you just to reflect back on how will you use epidemiology in your practice. You may simply use the findings of epidemiologic studies. You may use it in your screening methods when you look at sensitivity and specificity. And you may look at it when you're making your goals for what to focus on for community and population health. What areas of focus, what areas of prevention, what areas of education we can have with our patients and our clients for better health outcomes in the future. As I mentioned earlier, I'm working on my research now, and while a lot of people wouldn't probably classify interpersonal violence as a disease process, we certainly use epidemiology to look at incidence rates, mortality rates, and morbidity rates related to violence in communities. And so we really do use epidemiology across disciplines and across context areas. So best of luck to you. I hope you enjoy learning about epidemiology. And if you have any questions, Dr. Crary can help you to reach me. Thank you.